This podcast is sponsored by PACs. Whether on water, on land or in the air, PACs bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PACs bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PACs bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PACs bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PACs bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with me, Lisa Burrell. I'm joined today by Professor Mark Wilson, who, amongst the many hats he wears, is the Chief Investigator for the Spinal Immobilisation study, currently in progress across parts of the UK. The Spinal Immobilisation study is a randomised controlled trial of the clinical and cost-effectiveness of cervical spine immobilisation following blunt trauma. In this podcast, I'll be exploring with Mark the very real need for this trial, the impact it could have for those of us who work in pre-hospital care, and how it might form part of a more robust evidence base to improve the safety of decision-making for those we care for who have sustained or at risk of sustaining a spinal cord injury. So welcome to the podcast, Mark.
Hi, Lisa. Thanks for inviting us.
So, Mark, this might sound to those of us who've worked in pre-hospital care for a while like a bit of tried and tested ground, but it's not, is it? Many of us have spent some time looking at the evidence behind immobilisation. We might have looked at the Nexus guidelines of the Canadian C-SPAN rules and looked at the sensitivity, specificity of those tools that we use in practice commonly. And we've come to a point where we make some quite pragmatic decisions within our scope of practice, within the degree to which we suspect a clinically significant spinal cord injury. But it's not just that simple, is it? There is a missing part in the puzzle at the moment that we don't have. Can you walk us through the journey that's led you to this point to start doing this trial? What is it that we don't know, and what has led to the need for this trial for pre-hospital practice?
C-spine immobilisation has been controversial for a while now, but it goes on the background of a sort of 40 year history of it being indoctrinated in ATLS that triple immobilisation is the gold standard management following blunt trauma where you suspect there might be at least a cervical spinal injury. And that's become that was quite dogmatic in terms of how it was managed. And certainly from a medical legal perspective, it is still pretty much considered the gold standard of care, and deviating away from that carries medical legal risk, and also obviously risk to the patient potentially, although we don't have that much evidence around the real risk of that. So this was this study came about largely because it was considered about 6-7 years ago to be of one of the most important aspects of pre-hospital care that needed to be addressed to give a definitive answer, because it is used very commonly, and the levels of evidence around both the benefit and the harm are very poorly understood. So the NIHR did a survey, it's about 5 or 6 years ago now, looking at current perceived practice around this, and found there was a considerable variation amongst clinicians. It is also something from our PPE work that the public or potentially patients feel very significantly concerned about as well. And to briefly explain that, if you have the complications of triple immobilisation are largely considered to be things like aspiration pneumonia, pressure sores, raised intracranial pressure. The failure to do triple immobilisation, the perceived problem is going to be a spinal cord injury. Now, if you compare those two different complications, all those things we mentioned first of all, so the aspiration pneumonia, the pressure sores, ICP, they're all temporary. If you have a spinal cord injury patient in front of you and you do the PPE work around this, they will say, well, my spinal cord injury is forever. All those other things were temporary. I would rather have had any of those than my spinal cord injury. So it is a very emotive, whether or not it would have made a difference, no one knows, but it's a very emotive. And currently we don't have any kind of uh, measure, a quantitative measure of the two sides of that coin, whether they be the temporary things or the spinal cord injury. And the temporary things we might think of being a temporary. Everyone goes, oh, aspiration pneumonia, yeah, you get better from that on intensive care. Well, not everyone does. Some people die of aspiration pneumonia. So sometimes that harm could be permanent, but we just not quantifying it at all. So this study came about largely to try and put some numbers around that. And what the study is a randomized prospective study in two phases, a pilot phase, which we're in at the moment, then hopefully a larger rolled out, more national phase, randomizing the two populations to two arms, one of which is movement minimization, which is defined as being either two rolled up blankets or two head blocks on either side of the head, no tape over the head, and the patient can sit up to 30 degrees. And that's one arm. And then the other arm is the standard, which is triple immobilization, so head blocks, tape, collar, and the measure, the outcome measure of this is going to be the functional independence measure motor score at the time of discharge, which is a fairly generic kind of how are they functioning score, but that's to make the numbers work. That's probably the best outcome measure that we can use for that.
Yeah, it's so interesting. And I think it's one of the things that maybe we haven't thought about so much up to this point, in pre-hospital care. We've thought about the benefits of immobilization, but I think it's quite underexplored whether we've actually looked at the levels of harm that we might be causing. So that's why for me this is such an interesting study. Can you tell us a bit from your own personal journey with this? Have there been any standout cases in your practice, either as a pre-hospital doctor in a HEM system or as a neurosurgeon, that have really hit home to you the importance of answering this question?
So I think it's an important question to answer for many reasons. And as I've seen many patients who haven't had a spinal injury, who we've managed, probably focusing on protecting the cervical spine when we potentially didn't need to, and vice versa. So I'm sure we've all experienced patients who have, for example, got a head injury. They're quite prone of vomiting, and they do vomit, and then they aspirate, and you've not only got their head injury, you've also got the aspiration problem on there as well. Now, by all means, you can triple immobilize them and turn these scoop or whatever you've got them onto one side. But I think we're all familiar that's not a great way of managing someone who's vomiting. They too still tend to aspirate, especially younger patients. So so I've seen that side of it. I've also seen patients who I know have had a definite spinal cord injury with neurology, who you collar block and tape, and then you can jack up their blood pressure and they improve from that neurology as well. So I've kind of seen the spectrum of that, and I do see a lot of patients on intensive care once they've had their pre-hospital journey, who, for example, don't have a spinal cord injury at all, and who have an aspiration. You think, well, was there anything during their process in the pre-hospital phase that led to that? And then there's also the ICP rises and things like that. So from a personal level, I do see both sides of that coin, but I don't think we get the it's very difficult to quantify that unless you start looking at big data. And it may well be that there is a decision to make down the line that says, well, actually, in this, by doing triple immobilization, you remove or reduce the risk of having a spinal cord injury in one per, I don't know, pick a figure, 8,000 patients, for example. But in that 8,000 patients, you've got another 20 who have got an aspiration, of which 2 die. In which case you go, well, actually, you know what? On balance, it's a wrong thing to do. But we just don't have that quantity yet. But the reason for having this number is that one, mostly, so we can do the right thing for our patients, obviously, not put any people at any additional harm through an intervention that might not be necessary, but also reassure the patient that what they've had done was on average the right thing to be done, but also from a medical legal point of view. And a medical legal case against a spinal cord injury may cost many millions, 20 million sort of thing, if you've got a young person with a high cervical cord injury and it's deemed to be made worse by them not being triple immobilized. That's a huge cost, not just for the patient, obviously, which is a huge cost for the rest of their life, but also for the NHS as well. And so if we can answer this question, it will hopefully minimize the problems around that as well.
For sure. And I think we can be quite blinkered, can't we? Those of us that only work pre-hospitally, we don't get to see those consequences, and maybe we just don't think about that sort of ongoing impact of trying to make such safe decisions for people and trying to protect our patients. Perhaps we just don't get that insight into what happens with them down the line. So that's really interesting. I'm just thinking now, for those people who might be listening to this, who might see patients being recruited into this trial when they're out in their practice, what can they expect? What are the sort of real world practicalities of when a patient is included in the trial? What would they see happen for that patient?
Sure. So currently this trial is in a pilot phase, which is with South Central Ambulance Service, SCAS, and with London Ambulance Service. And we really are trying to encourage recruitment in any patient from an inclusion criteria point of view who would normally be considered for triple immobilization from a point of view of standard guidelines. So if they fulfill that entry criteria, then if they've got capacity and the situation allows it, then you can do a verbal consent type process, which is just verbal at that time. But we appreciate in the majority of situations, this is not going to be possible, either because they've not got capacity or because the situation just does not allow fully informed consent. So the formal consent process actually happens in hospital afterwards. But a verbal assent can be tried to get be obtained early on. And then the way that the person is randomized on seeing is through a web app, which if the paramedic is under training, they can go to the website, which can be stored on an app, either on their own device or on a personal device. They enter their own PIN, which is their PIN number to signify who they are, and then that person with a little bit of data about whether they're under or over 18 gets randomized to a standard treatment, so triple immobilization or movement minimization. Then that process is carried out. So if it's standard triple immobilization, pretty much everyone listening to this will know what that is. If it's movement minimization, then they have either 2 blocks or 2 rolled up blankets on either side of their head, those can be taped to the underlying scoop or trolley. So the actual blocks can be taped to the scoop, but the tape mustn't really go over the person's head. The idea of this is to prevent minimize lateral movement rather, but not to overly restrict them in the way that triple immobilization does, with all the discomfort that brings. And they can be sat up, if appropriate, to sort of 30 degrees as well. And then otherwise, it is exactly the same as normal. So they then go to a hospital, they're transferred over. Some hospitals will have a sticker system where they can say C-spine not cleared, but that's not always necessary. And then the patient goes down that pathway of, in the standard way, having their potential spinal injury assessed, whether it be clinically or with imaging as well. And then they are followed up. So they'll have a FIM score done at the time of admission. They'll have a FIM score done at the time of discharge. And then we have a follow-up process as well to make sure that they're A, they're consented, and B, that they can have a follow-up 6 weeks down the line.
Sure. And I think that all makes perfect sense. But I imagine as crews go out and start to do this, bits and pieces have come up where they're uncertain about exactly how to put it into practice. And I'm sure there's been questions asked, and particularly about how to maintain that standard when they hand over to other hospital teams who might be included in the trial, and all these questions. It makes it quite challenging, doesn't it? But it is such an interesting area to start making progress into, and great that it's a randomized control trial, that there's this gap in our evidence base, and we're going in trying to get really high quality evidence to make a good case for practice. But randomized control trials, as we know in the pre-hospital setting, are really challenging. What has been your experience of this?
So this is challenging because for a number of reasons. One is because it involves a lot of organizations. So you've got the ambulance services, obviously, first of all, but then you also got the hospitals as well. So recruiting those sites, getting them on board, getting everyone aware, trained up, is a process. I think also doing work in the pre-hospital environment, as everyone knows, is hard because you've also got the situation to deal with. So you're dealing with whatever's going on, the car accident or whatever it might be. And so having to do research on top of that is hard. So it's a big ask, but it is a really important ask. And the idea is that once we know this answer, it will hopefully make our lives easier in the future, in the sense that we can, with confidence, just do movement minimization if that's what the study shows, or no, we must stick with triple immobilization because that's what we'll have an answer. So I think it will help make our lives a bit easier in the future. But the really important thing is engagement here, and I know that everyone has got a lot of other stuff at the moment that they're having to deal with as well, and morale is not exactly great. I want to, if I can encourage people to engage this, because it is a really important question. It's certainly an important question for patients. And we're the only place in the world that we can really do this. If you look at the US, 6,000 ambulance services, they can never get themselves together to do this kind of study. We've got the volume, we've got the coordination to do it. So it'd be a really nice study for us to do it. And I should also say that if anyone wants to find out a bit more about this, well, look at it. There's a website, www.spine.study. So it's just spine.study. It's pretty easy to remember. All the information is on there. And there's videos and things like that on there as well.
Yes, and we can certainly tag all the relevant information for this trial in the show notes for anybody who wants to go and have a look at those afterwards. That'd be great. Thanks, Mark. There's of course a wider impact to all of this, isn't there? I mean, people don't injure their spines in isolation, and people don't get immobilized always for the right things. What do you envision might this study allow us to do in the future? Maybe not just for our spinal cord injury patients, but for other patient groups as well.
So I think that one of the differences with this study and most other pre-hospital studies is it's a physical study. It's not about giving X drug versus placebo, which is what a lot of the cardiac arrest type trials are, or bleeding trials are about X versus Y. This is actually a physical study. It's physically doing something or not physically doing something, which I think that's a big ask in the pre-hospital world, of especially as I say, when there's lots of other things going on. But that opens the way for other sort of studies of intervention, as in like physical intervention. Is this scoop better than that scoop, or is it this kind of stuff? So I think that from an academic point of view, it gives us an opportunity, if this is successful, to broaden this out into other types of pre-hospital intervention. But it also from our patient population, as you say, most of these patients who have got a potential spinal injury also have a brain injury, or potentially have a brain injury or other form of trauma, and it's important that we do see this as being not just a single isolated system, but it's part of a package of care for that blunt traumatized patient. Because what we do when we're looking after the spine is going to have an impact on their head. Even little things like sitting them up by 30 degrees. That's what I kind of want to be doing to protect as best you can protect their brain. So it has knock-on effects to not just the C-spine side of stuff.
Yeah, for sure. And I know that there's lots of people around the country now, or around the world, who are really interested in how we make a difference for our head injured patients, and neuroprotecting, providing a good level of neurocritical care in the pre-hospital phase if we can, and being able to sit people up has to be a part of that. So how we do that safely, this could be absolutely game changing, which is wonderful. Thanks. Yeah, that's been so interesting to sort of hear it all from your perspective, Mark. And I know that it's being received really well, and people are keen to do their best to start recruiting, and we'll see much more of this as time goes on. I guess the last question really is just to reiterate any final thoughts that we might not naturally have come across throughout the discussion so far, and just to reiterate any of the sort of key takeaway messages for us that we might not have sort of adequately covered so far.
No, I think they've covered everything. I think the important thing is it's an important study for patients. It's an important study for our practice. Really want to engage people in it as much as possible. It doesn't add any significant time. It's a very quick randomization process on scene. And if people have got more questions, or they can always get in touch with me, or have a look at the website, www.spine.study. Very grateful for anyone who wants to get involved.
Thank you, Mark. That's been such an interesting discussion with you. Thank you for the time. It's been an absolute pleasure to talk to you today.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.